Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
The guest on this podcast episode has no disclosures to declare.
Hey, everybody. Welcome to another episode of JCO After Hours. I am Shannon Westin. I am a GYN oncologist at the University of Texas MD Anderson Cancer Center and serve as the social media editor for the JCO. And as you know, we've been really excited to bring you a selection of really practice-changing research and hard-hitting topics that we hope you're enjoying. So today, we are going to be discussing the results of the PALLAS trial. And the paper is the adjuvant palbociclib for early breast cancer, the PALLAS trial results. And I would say before I get started that no guests have any relevant conflicts to disclose. So let's meet our guests. We are going to be talking today with Dr. Michael Gnant, who is a professor of surgery at the Medical University of Vienna and the president of the Austrian Breast and Colorectal Cancer Study Group. Welcome.
Thanks for having me on.
And I'm really excited as well to invite Dr. Kathy Miller onto the podcast. She's the Balve-Lantero Professor of Oncology at the Indiana University School of Medicine, Department of Medicine, Hem/Onc Division, and the Senior Deputy Editor of the JCO. And she's also an author on this very important paper. So welcome, Dr. Miller.
Hey, Shannon. Thanks for having us.
We're really excited to get into this discussion. I think this is a really important paper, and we're really excited to have it be published at the same time as the San Antonio meeting. So I'm hoping that our listeners are excited to get a little bit of an in-depth discussion around the results. And so first, if you would just, as you guys know, I'm a GYN oncologist. So give me a little background. What led to this trial? How did you come to put the PALLAS trial together?
Yeah, I think the background of the PALLAS trial is that very clearly CDK4/6 inhibitors have been added to the treatment armamentarium of hormone receptor-positive breast cancer a while ago. And there's actually, for now, 3 drugs that have all demonstrated in metastatic breast cancer excellent outcomes in the sense that the benefit, if you add these drugs to endocrine treatments such as aromatase inhibitors or fulvestrant, that you really markedly improve progression-free survival and overall survival in many instances. And we are talking about hazard ratios of 0.6, 0.55, 0.5 in these trials. And quite logically, I think that, the whole breast cancer community was trying to transfer this benefit to the curative early breast cancer setting. And that happened in a series of trials. Actually, there's 2 early breast cancer trials with palbociclib. PALLAS is one of them. Penelope B, also published in the JCO earlier this year. Then there is the Monarch E trial, also published initially in the JCO, now with an update in Annals of Oncology, investigating the addition of abemaciclib to endocrine treatment. And ribociclib is tested in a trial that is called Natalie, that is due to report probably in 2022. So that's the framework, bringing palbociclib into the early adjuvant breast cancer setting.
Great. I think, this has been a really hot combination that's been being explored. And as a GYN oncologist, we're pushing it. We're learning from what you all do in breast and are now looking at it in endometrial cancer, in low-grade serous ovarian cancer. So we read these results with great excitement and anticipation. I think one of the things that has been really interesting to me is as we're utilizing these different targeted therapies and hormonal therapies is trying to overcome resistance to these therapies, because this is what we're seeing develop. So can you talk a little bit about that mechanism of action of CDK4/6 inhibitors and how they potentially can overcome resistance to therapy?
So Shannon, I'll explain it to you in non-scientific terms. I think for many in practice, it gives them a little PTSD from their first biochemistry studies. So I think of the cell cycle and cells reproducing as the G1 to S phase is the crucial checkpoint. Once cells have gone through S phase, once they have replicated their DNA, they are essentially obligated to proceed to divide. So making that decision in teleological terms is crucial. And what healthy cells do is what we hope families will do. They take stock of, am I healthy enough? Do I have the resources to be able to reproduce? And if not, the cell cycle should halt and should stop them at that checkpoint until either the problem has been fixed, or if it can't be fixed, it should trigger those cells to die. So that's a problem for cancer cells. And for ER-positive cancer cells, depriving them of estrogen with anti-estrogen therapy in some way should stop them from dividing at that G1 S phase checkpoint. So disabling that checkpoint is a common way that ER-positive breast cancer cells become resistant to hormone therapy. And the cyclin-dependent kinases work, we think, by trying to restore the normal function of that checkpoint. So if you got around estrogen blockade, by stopping that checkpoint, restoring that checkpoint should help hormone therapy be more effective for more women for a longer period of time. And indeed, in the metastatic setting, with all three of the available agents, that's exactly what we see. And it's not surprising when you see such dramatic improvements in the metastatic setting, we quickly start to think, well, maybe if we use that earlier, in those at risk of recurrence, you would get an even bigger benefit. You would forestall recurrence and maybe prevent recurrence in some people entirely. And that's what led to moving these agents fairly quickly from their really dramatic metastatic results into the adjuvant setting.
It's awesome. And it's such a well-designed trial, big trial, but you enrolled so very quickly. So say you get a phone call next week, one of your referring docs, she says, I heard about the trial. I heard it's negative. What exactly happened? What are the results? Can you give me like your 2 to 3 minute pitch over the phone that you would explain what happened here?
I can try. Yes. First, you are right. It's a great trial, and it's it has been a wonderful collaboration, and it continues to be, of so many, in fact, hundreds, thousands, I should say, of patients and their families, but also hundreds and thousands of caregivers really around the globe. So this trial is run in 21 countries around the globe, and it is a joint venture of the Alliance Foundation of Clinical Trials in the US and the rest of the world, as you guys call it, operations, which are directed by the Austrian Breast Cancer Study Group in Vienna, together with the Breast International Group and many other academic groups. And I think that's the role model, how we should do pivotal clinical trials nowadays. And I have to say, to give credit to Pfizer, who were funding the trial, but they were not the legal sponsors, so they gave everything into academic hands, which I think needs to be appreciated. So it was a fully academically controlled trial. It recruited, as you said, quickly, almost 5,800 patients within approximately 3 years. And that obviously means that there is a lot of statistical power. And as it is custom and obligatory nowadays in these trials, we had interim analysis to ensure that, number one, there wouldn't be any unexpected safety issues that patients needed to be protected from. Second, not to continue a trial which has an overwhelmingly positive result. And third, also against futility, not continuing treatment that has only a very small chance of providing benefit. And when this trial, was running and everybody was waiting for results and the events came flowing in, and then at the second interim analysis, yes, to our surprise and somewhat disappointment, it's science, not a religion, but still you always have a hope and believing in something. And the second interim analysis indicated that it would be highly unlikely, based on the figures observed back then, which was earlier this year in May and June, that it would be highly unlikely to see a significant difference in the final analysis. That was published quickly, and the trial was transformed in a way that those patients who were still on treatment were moved to the follow-up phase. That was about 350 individuals. And now this is the final protocol-defined analysis. So it's definitely not the final analysis of this trial, because there will be results. We will have at least 10-year follow-up for every patient, which in luminal breast cancer also is essential to see long-term effects, to be able to analyze subgroups. There's a huge translational program. One of the achievements of PALLAS is that, in fact, and I will freely admit that in the beginning I was doubtful whether that would be a good idea, but we requested a mandatory tissue specimen, which used to be an option, more or less, until that generation of trials. And that was a huge success. So we have tens of thousands of biospecimens, blood samples, and also tissue specimen, and we continue to collect them from recurrences. And we are really extremely grateful to this donation of our patients and to the work of all the caregivers involved, because this is going to build the largest database and treasure of translational knowledge on luminal breast cancer ever. So, irrespective of the fact that I'm not hiding my disappointment about the primary outcome results, yes, we would have hoped for a difference. No, we didn't observe a difference. The curves between those patients who were receiving palbo in addition to the endocrine treatment and those who were receiving endocrine treatment alone are more or less superimposable. So there was no benefit. And the clear-cut conclusion is we cannot recommend the addition of palbociclib to standard endocrine treatment. But still, this is a successful trial. It continues to go, and it's going to build a huge research resource for maybe at least professional generations to come.
Great. I know that you did some subgroup analyses. Were there any groups or even any trends of groups that might benefit from this or have a hint or an inkling, being mindful of the weaknesses of subgroup analyses, of course?
Well, with such a large trial, I think subgroups can become powerful once the follow-up is there. We are not there yet. I can tell you, since I was fighting so much for the node-negative population in there, we have about 1,000 patients in there. It's the only adjuvant CDK4/6 inhibitor trial that includes node-negative patients, because they are usually left out because they don't produce, so to say, enough events for a quick result, which obviously everybody wants to have. So we will have a pre-specified analysis on these patients. We can interpret something into the forest plots right now. The cruelty of the numbers is all these tests of heterogeneity we look at are clearly non-significant, and that means we don't have a signal. So that's the politically correct answer. There are some indicators of hope, let's put it that way, and I'm actually very optimistic that program is going to help us understand why this doesn't work, and that will necessarily also identify subgroups for future analysis or even modified treatment approaches with these types of drugs.
It's great. And you're exactly right. It's such an amazing resource, and it was so smart to build that in, because there's nothing that hurts worse than a negative trial when you've put so much of your heart and soul into it. I love it. You said it's science, not religion. That I'm going to write that one down, and I want to use that one again. But it's true, because we have a lot of hope, right? When we put this together, we look at the science, we put together what we think is the best population and the best design to move the question forward. And our hope is that it's going to impact and help our patients that we see in the clinic every day. I guess my question is, I'd love to hear your comments from both of you on this one. Are there any elements of the design or things that you think might have contributed to the negative result? Is there something now, like if you had, if you knew then what you know now, would you adjust the population? Would you adjust the design in some way?
Shannon, I think Michael said something else really powerful that we should all remember. The PALLAS trial was not a failure. The PALLAS trial was a huge success. It was done incredibly well with worldwide partnership and enrolled patients very quickly to answer an important question. The answer is just simply the one we didn't want, and not the one that we expected. But that's not a failure of the trial. So our questions now need to shift to what did we get wrong, that led to this? Did we test the question in the right way? And if we tested the question in the right way and the answer is still not what we expect, what did we not understand about the biology of the disease or about the specific drug that might account to it? So we've looked and we're continuing to look at subsets. So far, no subsets that you could clearly point to say we should do this again, but limit it to this group of patients. We hope that all of the biologic work going on in the samples that were collected might identify that group of patients, but that work is very much in its infancy. I think this is also a trial where longer term follow-up is going to be really crucial. So we have to remind ourselves of the tension between our desire to get results quickly, particularly when we expect this is going to work. We want an answer as quickly as possible so we can make this therapy available to our patients. And that impacts the people we enroll. We intend to enroll people at higher risk of recurrence and at higher risk of early recurrence because then you get the answer quicker. But patients who have ER-positive disease have a really long natural history. More than half of ER-positive recurrences occur after the first 5 years. Mm-hmm. So that inherent tension may simply mean we enrolled a group of patients more biased towards those that are ER-positive, but less likely to benefit from any anti-estrogen maneuvers. That leaves open the possibility that with longer term follow-up, perhaps the curves will diverge. Perhaps not. It will take longer follow-up. But we have definitely seen trials in ER-positive adjuvant setting that did not start to see a divergence in the curves until 8 years after patients were enrolled. So this may also challenge us to think about how do we study ER-positive disease. And if we're really looking at hormone benefits and hormone manipulations, then the goal to get answers quickly just simply doesn't fit. I don't have a great solution for that because we do still want answers more quickly. We've tried to look at clinically relevant subsets. We've tried to look at those patients who would have been eligible for the abemaciclib trial, which enrolled an even higher risk group of patients. Even restricting the PALLAS population to that group of patients still didn't see a difference. So that begs the question of, is there a difference in the drugs? Well, they are different drugs. They do have a different toxicity profile. Their efficacy results in the metastatic setting, though they have not been directly compared, look really, really similar. Certainly do not look like you see such a major discordance. So that raises questions about, is the target of the drug really the most important target? Or is a drug that inhibits a greater spectrum of CDKs, like abemaciclib, better suited to this setting? It's going to take a lot more analysis of both trials. And I think at some point it's going to take a direct comparison of the drugs to really begin to answer those crucial questions.
It's interesting. I do think that this is a huge success. I wonder, Dr. Gnant, do you have a plan moving forward for that rich translational resource? And I think, Dr. Miller kind of started teasing a little bit about understanding the mechanisms and why this might be different, and especially like understanding the difference in that early stage versus metastatic group, where you saw this profound impact in the metastatic group, but then we're seeing not what we would have expected based on those results. Like, what are your plans to try to start teasing that out?
We call it the Trans-PALLAS program, and there is quite a number of pre-planned analyses according to RNA sequencing and many other very modern ways of interrogating our biospecimen. And that work has already started. But in addition to this, actually, we are inviting the global community to come forward with brilliant ideas, and we have actually opened the call for research project proposals, both on the clinical data level, but also on the translational biomaterial level. That's going to be open beyond the presentation of the final analysis results in San Antonio until mid of January, or more or less everybody can send in an outline with a good idea, and then we will have a review of that, and hopefully the smartest people around the world will think about this. So that's how we are moving forward. I mean, there is a number of potential reasons why PALLAS is a negative trial, whereas Monarch E obviously appears to be a positive trial. At least they have confirmed the benefit they have seen initially, and now with reasonable follow-up, they see a 5% absolute difference at 4 years, which is great news for that highest risk group of patients. So, Kathy has already alluded to, it could be different drugs. Yes, they are different, but they have more or less similar activity, at least in progression-free survival in the metastatic setting. So that may still be a reason, because the kinases are addressed in a different way. And as Kathy said, it's a broader view, a broader range that abemaciclib is actually targeting. There always has been a talk about the risk selection of patients, and I would really like to use this opportunity also of this podcast to put those speculations to rest. We have repeatedly looked at the monarch E-ish subpopulation in PALLAS, and on any other definition of highest risk, there is no signal there. So you can, and Penelope B, after all, has an even higher risk population, because that were the poorest responders after neoadjuvant chemo, which is in itself a high risk factor, and it was a negative trial as well. So we can actually put to rest that speculation. The next rumor and myth, I would call it, is that, well, patients in PALLAS, they had not the best of all drug adherences, and they didn't take the drug correctly, and that may have been the reason. Well, yes, because this was the first and pivotal trial, dose reduction and eventual drug stopping regulations in the protocol had to be rather strict, much stricter than we nowadays use them in clinical practice, which means that a proportion of patients needed to eventually stop the drug early, as the protocol was calling for. And that ended up in 45% of patients not really taking the full 2 years. We have modeled this multiple times. Even those patients who actually took the drug as protocol defined, there is only a smallish signal in there, far away from any significance. So that is not the reason for that trial to be negative. Now, this could be treatment duration. Well, we're not going to find that out, because Penelope B could have been positive if they've taken the drug longer. Natalie with ribo is actually using 3 years, so we're going to see whether that plays a role. But then now here comes my favorite explanation / speculation.
Okay.
I think in the early breast cancer setting, we are targeting quite a different enemy than in metastatic. I view these drugs as, and they are utterly cytostatic, a word that nobody likes, but in fact, that's what they do. They put up a stop sign for these tumor cells, as Casey has so nicely explained. And now in metastatic disease, we face an army of marching, proliferating enemy cells, and we put up our effective stop signs, and they stop. And then, because of the mechanism of action of the neutropenia we are exposing, we have a week's break, and the stop sign is not there, and they will slowly recover, and they will start marching again, but you still can win the war with your 3 week on, 1 week off stop sign. In early setting, our enemies are not marching, proliferating soldiers, but they are sleeping dormant somewhere, like sleeper cells in a war scenario. I'm not a military person, but still that's how I'm told it is. The challenge is much more difficult, because you need to cover your whole area, is our patient's organism. And every time one of these dormant sleepers is waking up and starting activity, you need to be there and put the stop sign there. And then we have a week where our whole police force is on vacation. And I believe it could make a difference whether we have a 3 weeks on, 1 week off schedule, or we have continuous treatment. That may not make a difference in the metastatic setting. If you follow that silly imagination about an army or dormant sleeper cells of any terrorists or something, then, I think it becomes clear that could be one explanation. Again, Natalie will tell us about this, because they have a different drug, and they have also 3 week on, 3 week off. If my speculation is correct, then that should also be a negative trial, which I don't hope, obviously, because it would be a missed opportunity for patients. But I think that's probably to me, after thinking about all this a lot and digesting our results and that of other trials, I think the most likely explanation is that what Kathy said about the different molecular targets of these agents, but also the continuous versus the intermittent treatment schedule.
Y'all have a real gift of taking really complex science and really making it very accessible. I thought both of you are just amazing guests, and I have learned so very much. Any last thoughts, Dr. Miller, about this?
It was really disappointing to see these results. No one works this hard and puts their heart and soul into a nearly 6,000 patient trial with the expectation that this won't work. I am still incredibly hopeful for the future and what we will learn from this. And I suspect that the biggest things that we as a community and our patients gain from the PALLAS trial will be from that incredibly rich biospecimen bank that would not have been possible if this work had been done purely by pharma. They may have collected the tissues, but they wouldn't make it available broadly to the community. And those samples are available for under an application process broadly to the community for questions not just about the CDKIs, but other questions for which having that biobank available can help us address. I suspect that this will be one of the trials a decade from now, not for anything about palbociclib. What we learned from that biobank and where that took us.
I couldn't agree more. I like so much, Casey, that you said, this trial is not failing. It's not a failure. The result was not as we were hoping for, but it's still a successful trial. And in terms of the scientific experience, I think Master Yoda of Star Wars has a quote, "The greatest teacher failure is." Mm-hmm. And I think we learn potentially more from a trial which primary endpoint turned out not as hoped for, and still provides the data and the resource to learn so much. I think we learned so many things. We learned that it is possible to request mandatory tissue collection before randomization. We learned that we can have really wonderful transatlantic collaborations, which was not always the case in the past, and we had such a friendly competition between so many groups around the globe, from Australia to Japan to Korea to Mexico, to environments where you wouldn't expect a high-level clinical research to be a natural asset. We learned that we can do it as academic sponsors, that we can deliver the quality that is needed also for regulators and for everything. And I think that's so much to build on. And yes, a hazard ratio of 0.7 in the primary endpoint would have been the icing of the cake, but the cake is still there. And I think it should stimulate and motivate those many who have invested in this trial. Yes, sometimes failure is teaching us something and success will follow, undoubtedly. I'm really convinced about that.
Well, thank you both, and congratulations again on a really well-designed and incredible implementation of this very important trial. Thank you both so much for coming on JCO After Hours. It was really fun. The time just flew by, and I hope to get to see you all in person at a meeting soon. And to our listeners, thanks for tuning in, and we will see you again next time.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement. For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.